So we are live, I think. So I would like to say good evening and welcome to this webinar that is organized by Dystonia Europe. And it is our first webinar in 2025. And my name is Monica Benson, and I'm the Executive Director of Dystonia Europe. And we are the umbrella organization for 21 national dystonia patient organizations in Europe. And tonight we have invited some speakers who are going to talk about children, dystonia, and DBS. And we're very happy to have you here. And unfortunately, our DBS patient who was supposed to be here couldn't join. So there will be no patient today, but we hope that we can organize another webinar with more patients involved, more like a patient panel. So later in spring, we hope to organize that. And this webinar will be recorded, and the recording will be on our YouTube channel later on. And please use the chat button and for any questions that you have. There will be a Q&A session after the two presentations. And also there is a reaction button that you can use if you like to. And after the webinar, there will be a survey with 6 questions that we appreciate if you can fill out. And now I will introduce the moderator for tonight. I would like to introduce Professor Alfonso Fasano. He is a professor in the Department of Medicine, Division of Neurology at the University of Toronto in Canada. And he also holds the title of Professor of Neurology at the Humanitas University and head of neurology of Humanitas Research Hospital in Milan, in Italy. And he received his medical degree in Rome, and he's been working in the field of movement disorder for quite some time, and with special interest in movement disorders and the treatment of neuromodulation. And he has authored more than 500 scientific papers and book chapters, and he's also the principal investigator of many different clinical trials. So I say welcome, Alfonso Fasano, and thank you for being here.
Thank you, Monica. Thank you, Dystonia Europe, for the opportunity to moderate this session. The first one, as you said, entitled Children, Dystonia and DBS. You already reminded the audience that Amibel, unfortunately, can't share her experience today, but she will be sharing the experience in your successful podcast, which I was part of, The Positive Twist. So once again, all the listeners and attendees today, watch out for this new episode of Positive Twist, because I know Amibel very well. I mean, very well. We've been on stage together, and it feels like I know her very well, and she's very inspiring. Now, as you know, today we're going to discuss the role of dystonia, the role of deep brain stimulation in dystonia, and particularly with an emphasis in children, where I would say DBS is mainly used with this indication. And I've seen actually in the attendees some known names, and including Laura Sif. So I'm happy that she's also attending. She's also very knowledgeable in this field. She's been one of the leaders in the field of DBS in children. So it's also obviously my role to moderate this session, and importantly, I have the task of introducing the first speaker, who is Dr. Margaret Kaminska. She's a consultant pediatric neurologist in Evelyn London Children's Hospital, which is one of the largest pediatric DBS centers internationally. She has a main interest in pediatric movement disorders and tone management. And what I also learned about her that she's very passionate about holistic care and improving quality of life for young patients and their family, which I think is very well said, Margaret. She studied in Warsaw and completed her training in pediatric neurology in Poland. And then I guess she moved to the UK 20 years ago, and she's been working in the NHS in the UK ever since. She's been working in a multidisciplinary complex motor disorder team, looking after children and young people with DBS and also baclofen and pumps since 2007. So she's always obviously very knowledgeable. I'm really looking forward to hearing from her. She's written a number of articles in the field, and really thank you, Margaret, for being with us tonight or today, depending where you're tuning in. So please, Margaret, the floor is yours.
Thank you. So I will try to share my screen, and thank you for a very nice introduction. Entire screen. Okay, let's see how it works.
It's working.
It's working.
Well, yes.
And if I now try to do the slideshow, let's just see how it works from the beginning. And
Perfect.
do you see the whole screen or only just my presentation?
No. It's good. You're good to go. Take it away.
I'm good to go. Perfect. Okay. So I hope it will be picked at the right level. Obviously, I don't know who are the participants, but the floor is open mostly for the parents, and I understand that everybody will have some more or less understanding what the DBS is for and what types of movement disorders in children do we see. So I will try to do a bit of the introduction, and probably a slightly more practical session will come from our clinical nurse specialist, Sarah Perides. But essentially, it's always good to start from the beginning and thinking before we jump into treatments. What are we talking about? What are the movement disorders? So essentially, movement disorders is the situation that we have too much or too little of the movements, abnormal movements, and grossly we can divide them into the hyperkinetic, when we have too much of the movement, and hypokinetic, when everything gets stuck, like in a traffic jam. When we talk about the dystonia, this comes under the umbrella of the too much of the movement, but it's not only dystonia that comes in this group. So they are very simple definitions. They are not very scientific definitions that I put here, but maybe a descriptors of how do we recognize this movement patterns. So the dystonia will be involuntary muscle spasms causing repeating twisting movements or postures. But we have also slightly different movement disorder called chorea. And these movements will be different. They will be very fast, random, to and fro, without any particular pattern, but not sustained, fast to and fro movements. Then we have other type of abnormal movements that we call myoclonus, and they will be very sudden, very short, shock-like. That can be like little movement of little finger, just one at a time, or they could be bigger movements of the bigger parts of the body. Why I'm talking about this three? Because actually very frequently we see the mixture in children of all this type of movements in the same patient. But all three of them can actually be amenable to the DBS. They are not the all type of movements, abnormal movements that we can see in children or in adults. There is many more types that well defined that will have different definitions and different names. But I think for the purpose of this webinar today, we will focus on sort of thinking about the combination of three. Now, as much as we try to be very precise, and there is a lot of discussions even within our department between me and my very good colleague, Dr. Lumsden, frequently he tried to be very, very clear about the definition. Yes, but we have to be very precise. What do we mean by dystonia? What do we mean by chorea? And we have to use proper names. And that's very true and very useful. But when we talk with the families, we are allowed to use dystonia term as an umbrella for a combination of this movement. So I don't want you to be put off and think that, oh, maybe my child has slightly different type. It's okay. We will understand each other. And then when we want to look into nitty-gritty of this, we can try and divide what is what. What I wanted to say that diagnosing the type of the movement can be really difficult. So frequently a specialist in movement disorder is needed to put a definition to recognize what type of abnormal movements this particular patient has. So that is a good starting point to sort of, look for the specialist movement disorder to really try and define what we are dealing with. And I want to mention status dystonicus, which is, some of you might know what it means, certainly the professionals in this webinar. But this is the situation that we see extreme deterioration of dystonia with constant or almost constant dystonic spasm in postures, causing discomfort, usually sort of poor sitting tolerance, usually severe sleep disruption. So something that is extreme, very different to the day-to-day movement disorder. It's a severe deterioration, and this might require quite a vigorous treatment. Now, probably 30 years ago, we were not recognizing dystonia that much in children. If we had a child with cerebral palsy, most of the people will call it, oh, they are spastic because they are stiff or athertoid. That will be probably the two main types. But ever since we started looking more sort of carefully into the type of movement disorders, into the type of tone, we are becoming more and more aware that actually dystonia is frequently a part of the pediatric movement disorder of the child presenting with the tone or abnormal movements. And this, I put here the information from the actually Toronto group, an American group. So they designed a clinical tool. I'm not going to dwell, what are the particular parts of this tool, but a clinical tool description, how do we tell the difference between spasticity and dystonia. And then they took 34 children with cerebral palsy as they came through the door in the clinic. And by assessing with this tool, they were able to define that actually close to 90% of them presented some symptoms of spasticity. But 80% of the same patients had presented some symptoms of dystonia. And that's actually now a classic example how these different types of the tone and movement can present in the same patient. And thinking that cerebral palsy is the most common cause of childhood disability, motor disability, then obviously we probably should take that dystonia might be much more prevalent in the children with movement problems than we had thought. So thinking about the management of dystonia, it's probably quite rare that we can, or maybe close to impossible, that we can treat dystonia like, for example, let's say tonsillitis. Okay, we have bad throat, we have tonsillitis, we give antibiotics for 7 days and job done, it's gone. With the movement disorders and as example, dystonia, we are gonna deal with a very long problem, and we can make things better. We can try to make life better. Sometimes we might be able to reduce the symptoms very significantly, and sometimes only a little. So we are entering a long road to try and help the young person with the symptoms of dystonia. Sometimes, indeed, diagnosis may indicate treatment, and it could be a certain gene that will point us that actually this treatment is the best one. Or it could be that, for example, movement disorder is a part of presentation of inflammation of the brain, which we call encephalitis. And then we have a good chance that if we treat the cause, so if we treat the inflammation, encephalitis, the movements will resolve. And in most of the cases, they will. So, but this situation that we can actually completely treat the dystonia and hope that it will never come back, they are not that frequent. Most of the time, it's going to be a chronic condition. So we have to look at all aspects of life, really. We have to look at the general health and think, how this is impacted and can we improve this? We have to look for triggers. We know that pain, for example, in different parts of the body could be, the earache will exacerbate movement disorder, or esophageal reflux, or constipation, or anxiety. or difficulty with feeding and therefore poor nutrition. So all these aspects of daily life we have to think about. Now, does this patient have appropriate seating and care equipment? Because if the wheelchair is too small, they are not going to be comfortable because of this, and therefore we can have exacerbated movement disorder. So very important to think about working with physiotherapy, occupational therapy, speech and language therapy to actually address different difficulties and think how can we help with equipment or with certain strategies. Communication difficulty. Sometimes young people with dystonia are thought maybe even less bright than they are because they might not be able readily to communicate effectively. So finding out how we can help with this, so actually they can express themselves. That's very important. And if we are able to do it, certainly there will be less frustration if their needs and wants can be heard. This will have an impact to appropriate school placement, and appropriate school placement thinking about how is the school able to support this particular young person? What kind of support? Are they familiar with similar young people? Do they have experience? Is the school work in terms of intellectual work, is it pitched, is it programmed at the right level for the right child? And of course, we can use some medication for dystonia, and we can think about some neurosurgical options. So thinking about medications for dystonia, when we looked at almost 300 patients referred to our service, actually 2/3 of them were taking medications, and quite a few. So the median was 2, but actually it was up to 5 medications coming like to the door to the clinic. The most frequent of them were baclofen, hexafenidil, and probably many of you have heard the names. Some of them, L-Dopa, diazepam was also quite a frequent one. But probably close to 90% of these young people had some adverse reactions, some side effects from the medication that were problematic in their life. And this was most commonly seen with hexafenidil, baclofen, and L-Dopa. So we know that it's sensible to try the medication with dystonia. They are not always very, very efficient. And if we have to introduce more, or we want to introduce more, we also have to think that we might be seeing more of the side effects. But sometimes we have to use a lot. This is just a medication list, an example of a young boy. I think he was probably about 9 at the time. He actually spent 9 months in the hospital because of the status dystonicus, which was extremely difficult to treat, and he spent months of the intensive care. So this is the list of medication that he had on the discharge from the hospital. So he was much better than throughout his admission. And you can already see that we have quite a big doses, gabapentin, clonidine, nitrazepam, even morphine at the time, which we try to avoid as much as possible, trihexyphenidyl. The others are for obviously abdominal symptoms, for some vomiting. So quite a lot for the gut disorder, which also can be a significant trigger and exacerbating factor for the movement disorders. So, is the deep brain stimulation a clear alternative? Okay, it is a management option of the symptoms, and if the dystonia is problematic and the treatment with medication is not successful, and all the other aspects of care that we can deliver, they are not making the trick, we can think about the neurosurgical intervention. We can see on this on the X-ray on the right-hand side the position of the electrodes. So that's this is how deep they go, and then they are connected with the wires under the skin, and they go to the wires are connected with the battery or stimulator, which can be positioned on the chest, but frequently in small patients will be positioned on the abdomen, because it tends to be better tolerated. But that depends on the center's preferences and experience and the size of the patient. on this, actually, this is an MRI scan. Actually, this is an MRI scan which is abnormal. But the point of this, showing this, is to show you that the tip of the electrode is positioned actually in the very center, almost in the very center of the brain. I think my mouse is going crazy. So these are the little points that the tip of the electrode goes into the globus pallidus, which for short is called here GPI. And this is the most common place that we place the electrodes for dystonia in children. And then through these electrodes, we deliver low electrical current, which is delivered continuously, so continuous stimulation with the setting parameters usually individually established, and this is based on the personal experience, the experience of the center. We learn from each other worldwide as well, so we learn different tricks of different specialists, and we try them all. But very much depending also on the individual response. So essentially, we look for something, for some settings that would work for this particular patient. The main indications for DBS, dystonia in the pediatrics, but in adult practice, very widely used for Parkinsonism. There's a growing experience for the epilepsy, some experience with obsessive compulsive disorder, depression, Tourette's. They are probably much less common indications, if not used very rarely in pediatric populations. So dystonia is our main indication. I have put here at the bottom of the slide the name of this dystonia rating scale, just because if you wanted to read up some papers reporting on DBS outcomes, you will see that most of the papers report the improvements of the dystonia following the DBS measured by this scale. This is like a video scale, and then sort of we give different points for different behaviors of different parts of the body, but it is quite standardized. It's actually whether it will be me, assessing this and giving the score, whether it will be Professor Fazana assessing the score, it's actually very reliable. So we will be very likely to assign the same score to the same sort of patient video. So it's a good score, but it's the disability. It's the score that measures the movements, but that doesn't measure functioning in life. So DBS is not a cure. There is no dystonia that DBS will be a cure. It may reduce symptoms. For some conditions, it will be fantastic. So it feels almost like a cure, or practically it will be a cure. But you can never say, unless you have encephalitis and be completely fitted, or sort of other very rare scenario. With the dystonia, you would never say that, okay, I'm completely free, I am cured. Most of the time, it's not a cure. I pulled here one of the actually summary papers. This was published in 2019, but collected all the reported cases from the literature and added who had DBS for the pediatric dystonia. And at the time, it was more than 300 children. And just to show that when we have cases, actually 1/3 of them were representing inherited dystonia, so like genetic dystonia, with normal brain scan, the improvements achieved on this, even of the dystonia rating scale, were really, really significant. So 76%. Obviously, some patients would have had even bigger improvement than that, maybe 90, maybe 95. But there would be some who probably had 60% of improvement, but that's really, really good. At the same time, we had a little bit, about 60 patients reported with cerebral palsy. And you can see that as measured by the dystonia rating scale, by the movement scale, it is a much more modest improvement, only about 11%. When we talk with the families in the clinic, we usually say that we probably would expect somewhere between 5 and 40%. So it's a bigger range when we have some brain injury. And also there are reports of specific conditions. For example, this is a neurodegenerative condition, but with this specific condition, the literature reports say that you can achieve sort of about 30% of the improvement. And this is a metabolic condition, specific glutaric aciduria, rare. Now the range of improvement would be only about 6%. And we are getting now to the stage that we can actually look up at which patients have been reported in the literature, and we can maybe even try to make the advice to you as parents more specific based on the sort of reported outcomes, that if you have this particular condition, you are likely to have this much of the improvement. So we can start talking about, is it worth doing or not? What was very useful observation in this paper, that they have found 18 cases reported in the literature of the DBS for status dystonicus. And in 16 of them, so vast majority, the status dystonicus resolved. So this emergency, the movement disorder emergency, was helped with the DBS. So this is about dystonia rating scale. Our group, our actually occupational therapist, Hortensia Gimenov, has published in 2014 30 of our patients, and she published outcomes by the goal assessment scale called COPAM. And in the 30 patients, whether they had a genetic condition or acquired dystonia, actually the improvement was significant in both of these groups. So maybe it's how do we measure the improvement that is important and tells you more. So thinking about the goals, for example, this is for the patients with cerebral palsy. This is how it's an example of a patient with our team. So what can we think about improving? So for this particular patient, what was important and actually was achieved at 1 year post DBS, that the dressing was much easier, the washing of the body was much easier, the comfort of the sitting, the standing transfers have not changed, but we are worried that whether they could be made worse, and positioning, sitting and hoisting was much easier. So this is an example of the probably relatively of modest goals, but you can imagine how important it can be in daily life. And thinking about that children with dystonia frequently suffered from pain, and some of this pain may be related to the hip deformity, but quite a few of them will have pain related to this dystonic muscle spasms. Dystonia can be painful. And we looked at this at our 140 patients, and actually 45% of them had identified dystonic pain before the DBS. And in 90% of them, dystonic pain was improved after DBS. So if we look at the dystonia rating scale, maybe not necessarily there was a big change, but it could be a huge change in life if you are now living without pain or with less pain. So how do we know which patients can have better response to DBS? We know that some genetic dystonias, we love them because they have almost magical response in most of the cases, not in all. Some of you may recognize this name of the genes if you have a child, that with this particular gene. But some other dystonias, particularly acquired, which example of which could be cerebral palsy, will have more modest response, but also can be which also can be meaningful. We want to look at the brain MRI. We ideally want to see as little brain damage as possible. There is no clear cut how much of the brain damage, brain changes, is gonna put us completely off the DBS for this patient. But the whole sort of movement disorder DBS community would like to see as little brain damage as possible to know that this patient will respond better. And obviously, very importantly, is the place that we want to put our electrodes healthy enough? So can we actually put the electrodes there? Now, this is still quite debatable, but there is some evidence that perhaps the duration of your dystonia, how long you have lived with your dystonia, could have a negative impact on your response to DBS. There are some papers that indicate, some analyses that indicate that this is true, and some that actually question this, but it is out there. Having said that, if you have a significant movement disorder, which is problematic in your life, why would you want to wait, endlessly or for years and years? and similarly sort of, for your children. We can look a little bit closer who can better respond by doing some neurophysiology studies, when essentially we measure the response of transmission of the sensory impulses and then motor impulses. And if these pathways are intact, if we have normal results, then we would expect better response from the DBS. So this can be really helpful, particularly for the acquired dystonia group. But we also need to look at goals and expectations. And while it is completely natural and understandable that every parent would want to have their child, to do as best as possible and resolve all the symptoms, it might not be possible in all the cases. So the expectations have to be realistic. To make them realistic, obviously you will have the sort of the team that is experienced in the DBS and treatment of dystonia to indicate what might be realistic. So we have the wish list, and then we have to bring it down and meet somewhere and agree what's ambitious enough but still realistic. And obviously they have to be related to dystonia. And every young person with dystonia might have other problems. So, and the difficulty might be related to these other problems as well. So we have seen a very exciting development of technology over the years. The experience in pediatric DBS for dystonia is probably about 20 years, and maybe a little bit longer. And ever from the beginning, just like, we need smaller stimulators, our patients are small. And indeed, the companies have worked hard to deliver on this. So every next generation of the batteries has been smaller, therefore easier for the small body to accept. And rechargeable batteries have started being produced probably at about 2008 or 9, the first came to life, and then the battery life has been extended. So while previously we would be thinking about the battery life between 2 and 5 years, more likely 2 or 3 for dystonia, now this battery life is going to be minimum 15 years, so we don't need the surgery to replace the battery. And a very, very recent development, and one of the companies who is one of the leading companies in the field, Medtronic, have developed this sensing technology. They've been working on this for years. And this is essentially an ability to recall like the EEG in the real life from the deep structures of the brain where we put these electrodes. Of course, a lot of work has been done. What does it mean? How do we interpret? How do we use it? And indeed, it has been found already very helpful in the treatment and adjustment of the DBS settings in Parkinson's disease. It's not that straightforward still with the dystonia, but it does open a window of opportunity to learn a lot about the dystonia, to find out which are the waves that we think, which frequency, because we have a combination of different waves recorded there, which will be more significant for dystonia. Will it be one type for every patient? Will it be that it different type for different patients? So we are going to learn about it. And are the same frequencies for adults than the young children? There's a lot that we should learn. But for some patients, there has been already sort of helpful to try and identify best stimulation parameters, like thinking which contact do I use, how giving the information from the recorded waves, and potentially this would improve efficacy or effects of the deep brain stimulation. It's also very encouraging that this new rechargeable battery with sensing technology is also currently the smallest volume of the market. So again, appears a lot to our population. And this is actually, there's just a couple of screenshots from the very interesting data from the sensing technology. This one is actually looking at the highest peak, sort of, the highest activity of the electrical activity of the neurons. And this is actually an example of a patient with dystonia Parkinsonism. And this enabled us to choose the the contact that the place that we are stimulating from, because you can see this is like a scheme of the electrode that has 4 levels of possible stimulation. And this whole thing is very small. The whole thing is about 12 millimeters. You can see that the spaces are about 1.5 millimeters, and each level of stimulation is 1.5 millimeters. But this analysis of different combination, recording from different combination of these levels, allowed us to pick up or to establish that probably this contact seems to be the most in the place that is most active, and maybe when we stimulate this, we will get the best results. But we also can review when the patient comes to the clinic. So this is like a recording of this peaks, but then it is like within the time, within a single day. And then we see that there's relatively low activity when the patient is asleep, and then they wake up, and then it starts to be slightly all over the place. And some of these peaks, we ask the parents to record certain events, and we call them dystonia in this case. And then you can have a look what is happening with these recordings at the time of these events. So with time, we might be able to use it to control better, maybe to deliver some stimulation settings that will control this moment better. So when to think about the DBS, when we have a combination of movements that can respond to DBS, so dystonia, chorea, myoclonus, causing some problems with comfort or function. It is a neurosurgical intervention, so it's only sensible to try other options first that are not that intrusive, not that invasive, probably at least a couple of medications, probably botulinum toxin injection is appropriate. And there will be some cautious, so we will be cautious in some patients, whether it is a suitable intervention for them. And realistic goals are very important. Caution. If this family lives very far and they have difficulty attending appointments, you will hear from Sarah that actually we need to work with the system once it is in. Poor general health and nutrition might have an impact how the implant might be, how the wounds might be healing, and will they be strong enough for the long anesthetic? The size of our patients. Our youngest patient was 32 months, but frequently it depends on the size of the head. There are some technical difficulties if it is too small, and the thickness of the skull, all this. So essentially, we might be ambitious enough to go down to 2 years, but at this moment in time, below 2 years, I think it will be. I'm not aware of the patients younger than that to be able to have an implant. And we have to think if somebody wants to continue playing rugby because that's their favorite sport, maybe it's not necessarily an option for them, because if they get a hit, in the battery site, they can have a big bruise, they can have secondary infection or skin breakage, so or displacement of the electrodes. So there are different aspects that we have to work out with the patient and the family. And this is just briefly to show it's our sort of pathway. What do we do? How do we approach, when we have the actual potential DBS candidate? I think similar approaches are used worldwide, but I'm well aware that it's not going to be exactly according to our points. So essentially, the first stage, we call it phase 1, with diagnosis and assessment. So we meet the patient in the clinic. It's usually the MDT appointment. So we go through all this sort of, what happened in the past, what have you tried, and all this, and what are the current problems. And then when we think that we have enough rationale to think about the DBS, either the patient already has had the brain MRI scan. If not, we really want one to look at, can we offer. In our center, other than for specific genetic dystonias like DYT1, meaning torsion 1A dystonia, we would do the neurophysiology study, this additional check, are these pathways waiting? And then we do have video appointment with the family to summarize what we found and give them very detailed information session about the surgery and what happens next. Then we have MDT case discussion within the team. And if we are all convinced it's a good way to go, then we do the baseline and goal settings. And then in our center, they are meeting the neurosurgeons. In some centers, it might happen earlier. With us, it's almost the last stage. And then the decision is made this way or another. And then we go to the sort of neurosurgery and post-surgical follow-up, and Sarah will talk a little bit more about it. So it is really a teamwork, and the team consists of obviously many specialists, neurologists, neurosurgeons, therapists, nurse specialists, psychologists, but also young people and families. So we have to work together to achieve best outcome and better quality of life for our young patients. With this, I would want to give the floor to our nurse specialist, Sarah Paredes. I will probably stop sharing now, so Sarah can do it. Yeah, I've stopped sharing.
Okay, thank you. Thank you for the excellent presentation, Margaret. And now it's my turn to introduce the second speaker. But before we do that, I think it's important to also remind our attendees that we are looking forward to receiving your questions. And there's a Q&A button that you can use. So don't be shy. This is your time to ask the expert many questions you might have. Sometimes I've seen that people might be afraid that the question might not be appropriate or the question might be stupid. There's no such thing as a stupid question. There might be stupid answers, but our panelists are great, so that won't be the case. And now, again, my pleasure to introduce Sarah Paredes. As you see from the screen, is an advanced nurse practitioner working at the Complex Motor Disorder Service at Evelina London Children's Hospital. And Sarah has an extensive experience of over 15 years working with deep brain stimulation and also intrathecal baclofen in the pediatric population. She wears different hats. She's also the treasurer of the DBS Nurse Association in the UK. And what I found particularly important, she has an interest in the transition of young people when they go to the adult services, which can be, it's actually a very overlooked problem, in my opinion. It can be quite intimidating for these people living with dystonia and their family to all of a sudden be switched to another service. And so it's important activities that she's focusing on. And also, I want to say just before she starts that I have experience working with nurse programmers, nurse practitioners in DBS, and without them, I won't be. I'll simply put, I'll be lost. So their role in the team, and obviously tonight we have a team, and that's how DBS is supposed to work, is fundamental. So having said that, Sarah, it's your turn. Looking forward to your presentation, and thanks again.
Okay, thank you. Can everyone hear me okay? Perfect.
All good.
Thank you. Yeah, so my name's Sarah Paredes. I'm a nurse practitioner, and I'm going to have I guess, a more practical talk, very much to children and families themselves, about the realities of moving forward with deep brain stimulation. So I'm going to try and cover what happens in surgery, what recovery can look like, living with DBS, talking about what things can go wrong, and answering the question, do they? And then we'll look at some follow-up and programming. But before I start, I just want to offer some advice to children and families going through this difficult process where you're thinking about whether DBS is the right decision for you. Just these things to think about, making sure your child has had a thorough assessment by a specialist DBS team, making sure realistic goals are set before surgery and you know why your child is being offered DBS. And then this is a difficult one, making sure you're as truthful as possible with the goals you're setting. And we understand hope, and Dr. Kaminska mentioned this earlier. It's such a powerful element in this process. But having realistic goals for deep brain stimulation has a direct influence on the outcome of the surgery. So there are three main things, and then this extra thing, knowing that DBS is not a cure, which Dr. Kaminska again mentioned. It can help with many things, but it can also not help with many things, including orthopedic problems, behavioral issues, weakness, spasticity. And also it's a game of patience, because unlike all the videos that you see on the internet about people having DBS and being switched on and then the movement stops, it's not the same for dystonia. It's a game of patience, and it's definitely not a light switch moment. So now I've shared a little bit of advice, I'll move on with the talk. So deep brain stimulation surgery in a nutshell. The basics are, it is brain surgery. It involves surgical implantation of 2 leads at the top of the head that are going deep down into the brain. And if you look at the image in the bottom right, you'll see how deep the area is. And then the second part of the surgery is implanting the second part of the system, which is the cable that runs from the head to the battery, whether that's placed in the chest or the abdomen. The only part that's in the brain are the 2 electrodes, but everything else is under the skin. So it's not visual. You can't see your battery on the outside. With very small children or skinny children, you can definitely see the shape of it, but it's under the skin. So what does that mean in reality? Well, there's a long anesthetic. So why is there a long anesthetic? Well, there's lots of other things that are happening in surgery. It's not just the surgical element. It's very intricate planning of how that electrode is getting to that very small target in your head, and that involves planning and scanning. So this happens in surgery while your child is asleep, and our patients are asleep throughout the whole procedure. So there's planning, scanning, cleaning, repositioning, re-cleaning, and lots of this takes up quite a lot of time. And then there's the checking of the elements as well. So that takes up at least half, I would say, of that long anesthetic, which can be between 4 to 6 hours. And you can see here some of the equipment that's used. But yes, there is the surgical element as well, which involves 2, in our service, I'm going to caveat that I'm talking about our neurosurgical technique here. There's 2 surgical C-shaped incisions at the top, quite small, and then 2 very small holes are drilled through the skull. You barely see the brain in this procedure. 2 electrodes are passed to target, and then they're held in place, and then they are scanned and checked that they're in the right place. And if the neurosurgeon's happy to move on, he then tunnels a cable or a wire from the top down past the ear and down to the middle of the chest and down to the abdomen, or to the chest if the battery sat in the chest. You can expect to have 4 or 5 different incision sites, and that's to, 1, get the electrodes in, and then the second is to pass the cables and put the battery in. They're small incision sites, but you are expecting a few after surgery. The surgery itself is actually tolerated very well. Recovery doesn't involve going to intensive care. You'll go to recovery where your parents can come and see you. Sorry, I'm in a dark room here and the lights have just gone off. You'll be in a recovery where your parents can come and see you, and then you'll go back to the neurology or the neurosurgical unit where you will spend your time. We have patients stay in hospital for up to 5 days after surgery. For pain management, we have a prevention is better than cure strategy, and all our patients go on a morphine infusion for at least the first night. And that's because we feel that a little amount of discomfort can drive a lot of dystonia. And we found by changing this strategy, our patients always have a calm first night, and it's a good start to their healing process. Feeding, you can eat or feed when you can tolerate your feeding. Some children feel quite sick after the surgery, and they might need anti-sickness medications, or they might need extra fluids. But other children wake up starving because they were fasted and now they've been not eaten all day. And I even had one patient ask for a cup of tea in recovery, which I know is very British, but it did happen. And then time in hospital. So like I said, they spend up to 5 days in hospital, longer if their recovery is needed. And then they'll go home, and usually they spend another week at home before they go back to school. So I would say recovery in the most part's around 2 weeks before they can get back to their normal plan. And you can see on the picture I put here, our hospital's the building on the right, and we're quite close to some tourist attractions. And children recover quite well from the surgery, and by day 4 and 5, they often go and visit some of these tourist attractions before they go home. So wounds, I'll just a disclaimer here, I am going to show some wound pictures. So if you don't want to see them, you look away. But this is the typical picture of what you can expect in recovery. Bandage and plasters, not that exciting. The child is smiling at the camera here, which you might not always get. But I was lucky to get some smiles in recovery for this patient. Now, in reality, We tend not to shave our patients' heads, and this is a few weeks after surgery where actually you can't see any wounds because the wounds are quite small and very little hair is removed. Again, I have a smiling patient here, which unfortunately I'm not showing. Now, the next pictures I'm going to show are of young people that have had their heads shaved, so the wounds are quite clear. These are more typical wounds, so small C-shaped incision sites on the top of the head. Different neurosurgeons use different techniques, and this picture that I'm showing now is a larger incision wound with an additional wound on the top of the head. We tend to put one behind the ear, but it depends what technique your neurosurgeon is using. We use dissolvable stitches, but other centers use non-dissolvable stitches or staples that may need to be removed. So, living with DBS. So you now have your DBS in, so we have to have the moment where your DBS is switched on. And again, different services do different things. Some wait a month before they switch the DBS on to allow for recovery. And some services switch on earlier. Our service is in favour of switching on earlier. Now, I mentioned before about DBS doesn't give you a light switch moment for dystonia. So when you switch the DBS on, actually, everyone's expectations need to be relatively low, and often we see no change. And that's often what we're happy with. We don't want to see any side effects. We just want to switch it on and send you on your way, getting used to the stimulation. And I liken it to a bit of a training program. So your brain is learning a new way to behave. So it takes time. It doesn't happen immediately. And the reports suggest that it can take months, 2 years, and even some reports are suggesting a long time into the future, your DBS is still changing the way your brain is working. Also, we only implant rechargeable stimulators. So yes, it's great. It lasts 15 years, but this is something you need to take on when you go home. And in simple terms, it's quite easy. You hold this device, the picture I'm showing you, over your battery, either holding it or using a harness or a belt. And that's essentially how you charge. But if you have a young child or a child with complex disability, where you have therapy and medications and handling and different elements like feeding, this is something else you're taking on. So it is an element of care that's added to your life. Follow up. So I always warn my patients that they're going to get bored of my face once the DBS is in, because we have so many appointments. You know, we're looking at 6 or 7 appointments in the first year as a minimum. We go from weekly to monthly appointments to 3 monthly appointments to 6 monthly appointments, and then we see them every 6 months afterwards. And that tends to be for setting changes, adjusting the stimulation. But we also, as a team, we work very holistically. So we're not just looking at the movement disorder, we're looking at their general health, their nutrition, their orthopedic issues, and we very much work like that. So you come to our appointments and we do a bit of an MOT when you're here. And then growing up. So as we've mentioned, I'm very interested in transition. And when I first started 15 years ago, I was really pushing and I felt like it was something that I couldn't change. And part of the UK Deep Brain Stimulation Nurse Association, we've really made good links. And now in the UK, when our patients turn 18, we have to say goodbye. And it's a very sad time for us. But we do send them on to the adult services, and we have grown good relationships with them. And they are now used to, we like to call it a new generation of patient going into adult DBS services. So just talking a bit about some of the restrictions that you might have. Dr. Kaminska mentioned them earlier. So we say no to trampolining, no to bungee jumping, no to contact sports, and then you have to be thinking about anything that's going to throw your neck around, acceleration, deceleration, activities that might damage the system. Because yes, once you have DBS in, there are complications that can arise, and they do happen. Our main worry is infection. You're putting a foreign body into a human body, and so therefore there is a risk of infection. Our infection rates are around 8 to 10%, and pediatrics have much higher infection rates than adult services, and that's internationally. They are very difficult to treat, so we have lots of things we try and do to prevent them, such as pre-surgical washes, nasal ointments, post-operative antibiotics. But if you get a DBS infection, most of the time you would eventually need to have some of the device taken out or all of it taken out, and then later down the line you'd have the opportunity to have it reimplanted. The next thing on my list is, I've written hemorrhage, but this essentially means when the neurosurgeon is passing the electrodes into the brain, there is a very small risk of a bleed, which is probably the most serious complication of this surgery. But it's very rare. Touch wood, we have not seen serious complications in our cohort, and even in the most at-risk group, this complication is very low. And then hardware and technical malfunctions. So if you were to go and play rugby and you had an accident and your battery got disconnected from the wire, you would need a surgical revision. And so there are multiple things that could happen. Fractures of the cable, battery failure, electrode failure, and these do happen, and we do see revisions. I've put seizures in here because this is something that can happen after any neurosurgery, any type of neurosurgery. During the recovery phase, there is a risk that you could have a seizure. Again, it's a low risk. In 15 years, I've seen one patient have one seizure. He went to casualty, it had stopped, and he's never had one since. But our main worry, I guess, is that we can't give you a guarantee, 100% guarantee that you will get the benefit that you've hoped for. We can give you all our knowledge, all our experience. We can analyze your child, with an inch of their life, and give you all the hope we can that these are the goals we think are realistic, but we can't give you that 100% guarantee that they will be achieved. And this is the paper Dr. Kaminska reported on quite a few years now, but we're still seeing these same complications. And onto technology. So there's lots of devices out there and about, but the main things you need to think about with children is size, as Dr. Kaminska said, and longevity. So we only offer rechargeables because they last longer, and we don't want young people to have to go through multiple surgeries. On to programming. Now, programming in dystonia is very challenging. There is some science around programming in the global pallidus. So the science behind it is that the bottom half of that target helps more. If you stimulate the bottom half of it or the bottom part of it, it helps more with upper body movements. And as you move up, you can help more with generalized postures. This is my way of teaching this in clinic. My upside down person. Now, this doesn't always help, particularly with children with dystonia, because their brains are different. They have some different scarring to that area of the brain as well. So it's not as easy as that. And with the increasing number of possible combinations or advances in technology, it remains time consuming. You can make different settings for different conditions. They talk about an insertional effect. So when the electrodes go into the brain, sometimes there's some swelling that can cause a beneficial effect. They call it the honeymoon effect. And then it goes away after a few weeks after surgery. We don't always see this, but it can happen, and sometimes that can also affect the way you program. But also, technology advancing is amazing. There are many things you can do now that you couldn't do 15 years ago. So the way the stimulation works is it gives constant pulses or constant stimulation into your child's brain, but you can change the power of those pulses. You can change the pulse width, how many pulses you're giving, but now you can change the shape and size of that stimulation as well. And that allows you to give personalized stimulation and reduce the risk of side effects. So like I've said, programming in DBS for a child with dystonia is very challenging. So I've just written here some of my tips and things you need to think about. So individualize your programming. It's definitely not one size fits all. Think about the child's self-perception at that time of the appointment. Think about the movement phenotype you're seeing before you, the age and size. So many smaller children don't tolerate the same settings that a bigger child can. And often at the beginning of their DBS journey, they tolerate smaller settings than they would a few months down the line. What's triggering the movements? Are they scared of being in the hospital room? And can you assess the effects of DBS in that environment? Have they just had medication? Are you seeing the effects of the medication and not the DBS? Trying to see the same patient time after time so you get used to how they respond. What were their goals? Have you already achieved the goals and now you're chasing something that perhaps is not achievable? Looking at the ability of the device, looking at who's making the changes. So sometimes, as hard as it is, patients just don't like you, particularly children. They're very honest. And you might be driving some of the movements yourself. I like to think all my patients like me, but it's not always true. And then looking at diagnosis. So has the patient in front of you responded better than you thought they would? Or are they not responding how you thought they would? And do you need to go back to scratch and look at some of the diagnostics again? And I wanted to end on, I guess, a positive page. And I think DBS for children with dystonia, you should absolutely do it for the right patient and the right goals. So I've listed some of the goals to the left here, but I'm just going to read a couple of these quotes because they've come from children and families themselves. I'm invited to the kids' birthday parties now. I have friends. It doesn't take us 4 hours anymore to get ready in the morning. I'm not thirsty anymore because I can ask for a drink. I've not felt pain since surgery. And thank you for giving our child back. So these are quotes from some of our families after deep brain stimulation. Thank you.
Amazing. Thank you, Sarah.
Whistle stop tour.
Yeah, no, amazing presentation with a lot of practical tips, because at the end of the day, DBS is a practical topic, and also I appreciate that you ended with words of hope, and DBS can indeed be life-changing, as we know. So while you both were presenting, I had a chance to monitor the Q&A function, and there are a number of very interesting questions, and some of them I would say have been meanwhile answered, but I don't think it is too bad because we have time to go through them, even if there are some repetition, because these are important topics. So let's start from the first one, which I guess, well, you both can answer. But I was saying it might be for Margaret because she did talk about sensing. And the question is from Jill, was saying, for children with poor signal transmission, is there anything that can be done to improve that? I'm assuming it was sensing that Jill was referring to.
I think that it wasn't sensing, and Jill, just type your answer if you think I got it wrong. I think you are talking about the sensory and motor transmission that I mentioned. And this would be more of a measure of actually damaged pathway. So unfortunately, at this stage, we cannot do anything to improve this, with the one caveat that the speed, sort of the speed and the how good the transmission is, develops with age. So if this, we know that the child above 6 years of age should have sort of, very good transmission. So if we are thinking about the DBS earlier and we see the transmission is slightly slower, we can probably wait and repeat the investigation after their 6th birthday. And so the time may help because the brain is still maturing. But if beyond that, if we clearly see that there is disruption of the transmission of sensory and motor signals, unfortunately, there isn't any treatment that we can give to improve this. Jill, if you can show your reaction, or just if I haven't responded, just maybe type a question again.
No, thanks for the answer. Now, yes, it was probably referring to the screening that you guys came up with to understand what's the underlying structural integrity of the brain, which is indeed needed for better DBS response, as we know. Another good question from Adrian now was raising the issue, which we see often, of people with CP, cerebral palsy, where often you will see a combination of different problems. And in particular, well, I guess this comes, I'm thinking about dystonia spasticity right now, but in particular here, there's a question about dystonia and epilepsy. And so the question is DBS going to affect epilepsy? And if it is possible to have at the same time VNS and DBS? And what's the difference between the two, VNS
Yes.
and DBS?
Do you want me to touch on this?
Whoever is comfortable. I'm sure,
Yeah.
because I know you work as a team, so I'm sure
Yeah,
that
yeah.
the
Of course, that's
answers
fine.
are pretty homogeneous. So
Yes.
whoever makes
So
it.
it's a very good question. It's not the one that actually we think about it we thought about it in quite a few cases. It's still not very common to have the DBS for movement disorder and VNS implanted. It's not impossible. It's possible to have two implants, but of course we have to consider that with each implant you have again a risk of infection of the implant, so it's a bigger thing to have both. It's not impossible, but it has to be very carefully considered. Now, the deep brain stimulation implanted for movement disorder, as far as we know at the moment, does not influence really seizures. I'm not aware of any evidence that children with the DBS for dystonia would have improved their seizures. Apart from the very acute complication post-neurosurgery, the DBS for dystonia does not cause seizures. Okay, so that's again sort of it's a good thing to know. So they can coexist. There will be sort of additional limitations. For example, if you have VNS one side, you probably want your DBS to be quite far apart, because if you interrogate one of the devices, you may inadvertently interrogate the other device. So there will be some limitations to it and extra precautions. It's not impossible. It's not routinely done as such. But yeah, it can be considered. Do you think the same, Professor Fasana?
I do, of course, and by the way, I'm Alfonso, but and I want to say that the question. Well, I can tell you my experience. We've done quite a bit of VNS and DBS because the Hospital for Sick Children, we do DBS for epilepsy too, which is off-label in kids. But basically the same principle applies. Just to be clear, DBS in adults can be used for epilepsy as well. In a different brain target. So from a technical standpoint, what happens is these people, I would say very often, because they start with VNS and then they go to DBS. So we have the coexistence of the two devices relatively often, and we don't really see problems, as you indicated. Maybe you can continue just quickly mentioning what's the difference between VNS and DBS, because the audience might not be familiar with that.
Okay. Yeah, so the DBS is the electrode that goes sort of, into the brain tissue. And as Alfonso mentions, that there will be different targets for the seizures and different targets for movement disorder. While the VNS is actually stimulation of the vagal nerve. So actually you have like a little coil. It's more like in the upper neck around the vagal nerve. So it doesn't really go into your brain as such. So it's and there are different effects and different mode of working, although both use small electrical current. So the DBS, you will have the electrodes in different structures of the brain. Like with the VNS, it will be around the vagal nerve, not so much in the brain tissue.
Thank you. Great summary. Now it's time to hear from Sarah, and I'm sorry to go back to you, Sarah, with a difficult question, but it's an important one. This is a question that is related to the daughter of Nikki, who's 8, and the daughter unfortunately has a rare genetic dystonia, form of dystonia. That involves different parts of the body, including different functions, including speech and ability to articulate words. So I would imagine there's dysarthria here. And the speech has worsened over time, and levodopa has been beneficial. And on dystonia and pain to some extent, but importantly, they noticed that the higher doses of levodopa helps speech, but it came with side effects. And now, obviously, we don't know what side effects in particular levodopa caused. That might be important to know. But the question is, and they tried baclofen, but it has some problems. The question, and I'm sure this is something you cover a lot in your teaching with patients, is whether DBS would be an option to help the facial muscle and the vocal cords.
So unfortunately, we never set speech as a goal for deep brain stimulation because we just don't see it improving after the surgery. A few cases where families feel that their children's speech has improved a bit, but to us in clinic, we cannot see changes. So we just don't set the goals. We often report if the families feel that this is an important element to them, but for the service, it wouldn't be. We wouldn't go through DBS for a speech goal.
Yeah, amazing. Yeah, absolutely. I agree. Unfortunately, it is what it is. And setting expectations is the key to success. But obviously, we don't know what in this particular case are the side effects of levodopa. I will argue that if the side effects of levodopa are dyskinesias, you might think, or involuntary movements, you might think that DBS might be beneficial in that regard, so that you can use more levodopa that in turn can help speech. This can be a little convoluted also because the other thing that is worth emphasizing is that DBS itself can worsen speech. So that's something that we need to acknowledge. And sometimes because of the, as you guys have seen, the technological advances, we can now shape the electrical field in a way that can possibly help speech, but this is not always the case. I don't know, Margaret, if you have any additional thought.
No, I completely agree that it would have been. I mean, we have seen improvement of speech in like in the
Some
in
cases.
some genetic dystonias, but this is really, really rare. So most of the time, again, we are not setting as a goal. I think, talking with our speech and language therapist, maybe if the speech is affected by actually sort of the discoordinated breathing because of the muscle twisting, you have slightly better. So again, sort of needs careful assessment. But if in the sort of typical like whispering dystonia, we would not expect speech to improve that much, unfortunately.
Yeah, and the bottom line is that doctors try not to inflate expectations. So if we are surprised that there is a good effect, we're all happy, of course, but we don't want to, especially for problems that are not really homogeneously improved, we try to just say it won't work. So it's important, otherwise people will be disappointed. So I have two questions from Aldo, and I guess one for Margaret, one for Sarah, and I'll start with Margaret, I guess, because that might be more related to the expertise of a neurologist. Aldo is asking whether there is any news on non-invasive brain stimulation, particularly TMS, transcranial magnetic stimulation.
So it has been looked now at for years. Unfortunately, it is still not a viable option for the ongoing therapy. So the systems to deliver this are relatively big. For dystonia, you need this continuous stimulation. So it's sort of practically quite difficult. And yes, people, particularly in the adult studies, have noticed that after a period of the transcranial magnetic stimulation, you have a period of improved dystonia, but then you have to repeat the sessions. So it has not come yet, to the really sort of used in real life practice for the young patients.
Thank you. And now back to Sarah. The question is about the surgical risk, which you covered, but as we said, better to repeat few important concepts. The risk of going through the brain with an electrode if there is any damage.
So as I mentioned, there's a very low risk of having a bleed to the brain when they pass the electrodes through, and that's why the planning in the surgery is so important. At planning the trajectory, and we haven't seen significant problems like this in our service, but I know there are reports that this can happen, and I guess if you have a bleed in the brain, there is risks to life and increasing neurodisability if it's significant, but it's a very low risk.
Yeah. And a lot of parents I met have the concern that just the fact that there are electrodes in the brain per se, even without hemorrhages, damages the brain. Do you have an answer to that?
Yeah, lots of people think, not just families actually. If you put something in the brain, it will damage it. We don't see this.
Important to mention. It is a relatively, it is a safe procedure, but like any operation, anytime you are in an OR, there are risks. This is what it is. Now, Lena is asking an interesting question that is actually something that it's a curiosity, but I think it's important to address that too. And Lena is asking, why are children's surgery done under general anesthesia while adults are awake during DBS? So who wants to take this?
Shall I go?
Yeah, go.
Go ahead, because the next one is for Margaret. So take
Okay.
it. Yes.
For DBS, for dystonia, like I said, you don't see an immediate effect. So my understanding is in adults, when they're awake, they're testing the effects of the DBS. So you won't get that with dystonia. But also, putting a child awake into a theatre room must be terrifying for them. So I think ethically, it's not very fair to put a child and wake them up or have them awake in the operating room. So that's my personal opinion there.
Yeah, of course. And if I can wear the hat of the adult neurologist, which I am, the adults are usually affected by conditions like tremor or Parkinson's that tend to improve on the spot. That's an additional way to understand whether they are doing better. I would say that even in adults with dystonia, we don't see much in the OR, but in general, I would say the field, because it's true, it would be unethical to put a child through awake surgery, but if you think about it, it's pretty unethical for many people. Even I met many adults that are quite scared and they don't go for surgery, or they are traumatized by the awake surgery. Many do very well, the majority do very well, but some are anxious about it, and as a result, more and more now asleep surgery is done even in adults. So I hope that this is what Lena wanted to know, and we cover the whole spectrum from children to adult. And now back to Margaret. We have our own Laura Sif, as I said, that out of her very busy schedule, I'm sure, decided to spend the evening with us. And she's asking a question, Margaret, for you. She's thanking you for the presentation, and she wants to ask about your experience with clonidine. Particularly, the question has to do with the success rate in terms of percentage to wean off clonidine severe dystonia, including the ones that had a status dystonicus. And also the other question is from those who benefit from clonidine, how many are on clonidine in the outpatient setting, and for how long? Before you answer the question, just a clarification, clonidine is a drug. It's actually a drug used for hypertension, but in kids has shown to be beneficial in many respects, particularly in voluntary movements. And status dystonicus is an important condition that is very often overlooked and unknown, which is a severe worsening of dystonia requiring hospital admission. So having laid out the explanation of the medical terms, Margaret, what's your experience with clonidine?
Okay, vast. Okay, a lot of patients on clonidine.
Do you have slides on this, or?
Well,
I'm joking.
I probably do somewhere on a different presentation, not on this presentation, because
Yes.
probably not quite enough for the purpose of this webinar. So if we're thinking about the patients who have had status dystonicus and continue to have severe dystonia, then complete wean of clonidine is almost like unseen. We will continue them on clonidine once they are stable and they are well enough to go home. We would continue them on clonidine, perhaps lower doses, long term. Maybe with time, I can think about the patients that we were able to gradually sort of reduce, particularly if the deterioration of dystonia was triggered by something. For example, we can start clonidine because they have had a spinal surgery and the movement disorder got destabilized seriously. So we can put them on clonidine, and then, a few months down the line, we might be able to wean them off. If there was not such a trigger that can be removed with time, probably in most cases, we will continue this medication really long term, although we might be able to reduce doses. So, but I can imagine the scenario, for example, if we had this patient who potentially may respond fantastically well to the DBS, particularly with some type of genetic dystonias, this would be the cases that we would probably be likely to win the clonidine off. In most of the acquired dystonias, very likely that we would need to continue long term, although we might reduce the doses. I hope this answered the question, but Laura, of course, you are very welcome to call me or email me if.
Okay. I'm pretty sure it does. And we have many questions, and we have 7 minutes. So this point is probably better to give short answer. Jill, by the way, is meanwhile saying that you answered the question, and yes, you were right. It was referring to somatosensory functions. And Jill, the infection per se doesn't affect the stimulation operation. It's just a matter of treating the infection, because that can be dangerous to the brain, because it's another question that was asked meanwhile by Jill. So Katerina is asking a question important, similar to what's been asked before. So if it's possible to have DBS and at the same time pacemaker, like a cardio stimulator, or a cochlear implant, which can happen indeed quite often, especially in people with kernitters. So any word? DBS and additional devices.
Well,
yes,
okay.
it can happen.
Cochlear implant. It's a big struggle. It's a very technically difficult to put the DBS when you have cochlear implants in. It's close to impossible to get good MRI scans. So actually, for this purpose, frequently even the scan would have been done really ages ago before the cochlear implants went in. So the pathway that we sort of at the moment we are thinking and develop, that the magnets would need to come off, do the MRI scan if still suitable, put the DBS in, and then reimplant the magnets at later stage. And each surgery carries on risk of infection. So it's really technically should be possible, but it's really difficult to coordinate. We have had some cases that had magnets removed, put them back in. We tried one case that's sort of doing at the one settings, then we got infection, the whole thing had to come out. So we have to think of it's difficult. It's not entirely impossible, but it's difficult. Now with the cardio stimulator, I think I would be really worried. And honestly, I would probably ask Medtronic, but I would have huge hesitations, because we have sort of both devices potentially working with the with the current, and also the question would be would the sort of delivered cardio stimulation, would this have a negative potential risk for the energy to travel through the brain electrodes? I would probably need to run this question freshly through the company, but that would be a very difficult scenario.
So sorry to rush. We have 4 minutes left. Just want to say that we have adults with pacemaker. Adults often have pacemaker, and it is not too dangerous. It is just important to, as you said, get the company involved. So in short, in principle, nothing is impossible. It just requires some extra caution. So there's a very important question from an anonymous attendee. And again, we have 4 minutes left. But the question is there any type of dystonia, and I would say probably genetic dystonia, that because of a particular etiology, you will not go for DBS, so based on what's known at this point, even though the dystonia might be severe?
I think will it be? I don't think we will ever say 100% no. I think it will be always very individual case, because even with the genes that not typically respond, like we have rapid onset dystonia Parkinsonism, I know that quite a few patients have been reported with really poor response to the DBS. So a priori would think, no, we don't want this implant these patients. However, there can be some differences in presentation in specific scenarios. It's probably still worth going for the and discuss it with the DBS center, because it might be slightly different presentation, might be slightly different sort of advice given. But yes, there are diseases that we would be very carefully thinking, is it really worth implanting?
Thank you. I see Monica. Monica, do we have a few more minutes, or we need to close? Because there are a few other questions coming in. And oh my, there are many. So Monica, tell us, can we continue for a little bit?
It depends on you. Do you have an extra 5 minutes so we can finish?
Of course, of
Oh,
course,
yeah.
of course. I
Yeah.
hope the speakers too. Okay, but let's go through them all. And actually, just touching upon what's been said, there is always an exception to the rule. Mark is saying that he has ST and DBS and improved speech. I've seen this, but it's quite rare. And it's rare, therefore, we never promise that speech will be improved. But going back to what we said. Quick answer, if you guys can, either Sarah or Margaret, can adolescents or pubescents influence dystonia? So is a teenager going to be different?
Very briefly, yes. And we've seen many times that the dystonia destabilizes completely for the puberty. And then we struggle in the pediatric service. And then once they are stabilized again, we transition them to adults. That's fairly frequently we've
very
seen
common
this type of scenario. Yes.
Yeah. So and the adult neurologist has an easier life.
Yeah.
So a quick question, and by the way, I can answer to make it fast. Dyskinesia, is dyskinesia a form of dystonia? It is just a different nomenclature. I would say let's stick to dystonia. Dyskinesia used to be used to indicate all the hyperkinetic involuntary movements. Nowadays, we consider dyskinesia as mainly the chorea type, the involuntary movements, and we use mainly in people with levodopa-induced side effects or side effects of other drugs like neuroleptics. So the answer is yes and no, but let's stick to dystonia to make it simpler. Now, question for you both. This is another important question from Katerina. Is there any difference in the procedure between verbal and nonverbal patients? I would say particularly the programming phase.
The programming?
I would say, yeah, I would say, because that, in my experience, this is where you may see most of the challenges.
Well, I'm happy to take this one.
Please.
It's about your programmer's experience and knowledge of the patient. So essentially, you're programming for the same outcome, but someone who can tell you how they're feeling is slightly easier than someone that can't. But then you have to know your patient. So if they look uncomfortable, you have to understand what that looks like in that particular patient and working with the family. So you adapt the way you're working, but your programming is the same.
I personally rely a lot on the parents because they will know what's going on better than myself. So moving to another question again from anonymous attendee. I don't know if it's the same anonymous attendee, but another very good question, which is whether levodopa, and I would say even other drugs, and botulinum toxin is reduced or not used at all after DBS. Margaret.
Yeah, I think I can take it. It's obviously we are talking here about probably a big bag of different conditions that can be treated with these two agents. Yes, if DBS is successful, we would see the lower need for the usage of L-DOPA, and probably we would see that you need less of the botulinum toxin. Either you don't need the injections at all, or you might have improved movements. Like, for example, if the patient was getting toxin into arms and legs, you might now see that maybe just one leg, still needs addressing with toxin. So yes, frequently you would probably see the use of less botulinum toxin, but it is individual, and dystonia is fluid. So whatever happens within the first 3 years, particularly when you are a young patient, may change sort of with time.
Very good. So we're almost there. There is a question that is probably, unfortunately, easy to answer. Someone Marija is saying that the daughter has KMT to be dystonia, which is known more and more nowadays. And we know the DBS works well for them. But the question is whether there is any type of research, particularly genetic therapy for this dystonia. Are you aware of any study in this sense?
No, there isn't at the moment a sort of genetic treatment for this particular type of dystonia. We are hoping with time, we are seeing more and more in neurology that these treatments are being developed, but no, for this specific dystonia,
not at the moment.
No.
Yeah. Eva is reminding ourselves about the GNOW 1 conference. GNOW is a typical genetic condition where you have actually hyperkinetic disorders of dystonia, even in chorea and status dystonicus, and also epilepsy. So there's a conference you all attend. So a little commercial here. Follow the event on social media. An important question from Adrian that there can be a long one, but let's see if you can make it short. Are the DBS guidelines always changing, allowing more complex dystonia cases to have access to surgery?
Okay, not sure that. I think any guideline is always changing. Indeed, the guideline is only valid until the next review. Actually, for this to be completely valid, you should be reviewing your guidelines every 2 years, but you might be surprised how quickly the 2 years mark comes. So probably in practice, we are constantly reviewing practice, looking at what people have published, and then think, okay, well, if people have access with this condition or in this scenario, I'm gonna try and do it. So to an extent, yes, the guidelines continue to change. Who do we implant? How do we implant? What will be best? Yeah, and probably more complex dystonia are accessing the surgery and it's becoming sort of more available worldwide intervention.
Thank you. So I think this was the end of the question. There is a comment, a question from a request, I would say, from Carlita from Ecuador. We're sorry to hear your story, Carlita. I would suggest that you connect offline with Dystonia Europe, and we can see what can be done. It's not easy to help from distance, obviously. And with this, again, thank you to the speakers for their excellent presentations and answers. And now back to Dystonia Europe. Thanks again.
Thank you.
Yeah, thank you very much to Sarah and Margaret, and thank you, Alfonso, for moderating the meeting. And thank you all the participants and all the great questions and answers. Very nice, very interesting, and we have learned a lot tonight. And as I said, this is recorded and will be on our YouTube channel. So you can go back and you can see the presentations and you can go through the questions again. And I also want to remind you, like Professor Fasano said, about the podcast with Amy Bell. So that's being launched end of February, so you can listen to her patient story and her experience with DBS. So, and then when you leave, don't forget to fill out the survey with the different questions. Very important for us to hear back, to get your feedback. And thank you again, everybody, for spending the evening with us. And I wish you a good evening and hope to see you soon. Thank you.
Bye-bye.
Bye.